First page, ma'am.
You do have GP letter.
Okay, next page, ma'am. Any other pages, ma'am? That's it.
No.
Hi, I
Started.
am Dr. Muthulakshmi, one of the exam candidates today. I read the instructions and ready for the discussion.
Okay. So, what will you find on clinical examination in this case?
So here the situation is with 43-year-old patient with complaints of postcoital bleeding and irregular and foul-smelling vaginal discharge, and with one child 5 years ago with five lost smear. Can I show it? No? Sorry. With 5 years ago, it was normal. So with a suspicious cervix and suspicion of cervical cancer, so we need to take a detailed history, examination and recommendation as per the assessment. So first I'll introduce myself to the patient and will ask her concerns in detail with respect to bleeding and discharge, onset, duration and progression, and any disturbances with the bowel and bladder, and about her last menstrual period and any heavy menstrual bleeding, intermenstrual bleeding apart from the postcoital bleeding, and any contraception she used before, and any sexually shared infections here, and she has done any HPV vaccination, and her age at the first sexual intercourse, then obstetric history in detail, and apart from this, and any other medical conditions or any medicine she is taking, any other surgeries in the past, any allergies to the medications, and any family history of clots or any gynec cancers like breast, uterus and the ovary, and how is her support at home, her personal habits, BMI, blood group, and any reservations for transfusion, and examination. So we'll check her pulse rate, blood pressure, oxygen saturation, and the temperature, and general examination. She'll look for the whether she's having any signs of muscle wasting, cachexic features, anemic. Anemia because of the malignancy, and also pedal edema because of any kidney failure or heart failure because of the anemia, and any lymph nodes, inguinal lymph nodes will check, and abdominal examination to look for any mass, any organomegaly, any free fluid, and any enlarged uterus or any this needs to be looked for, and speculum and the vaginal examination has to be done after getting a consent in presence of a chaperone. So we look for any visible lesions in the cervix, whether it is a friable, exophytic or a infiltrative lesion, whether it bleeds on touch, and we need to check whether the fornices are involved, vaginal walls involved, and by doing a vaginal and rectal examination to check for the parametrial involvement, and look for any uterine size, so that is enlarged because of hematometra, mobile or fixed in any adnexal masses.
Okay. What investigation will you undertake to reach the diagnosis in this case?
So here patient will be offered a BBN. So investigations first for her general health, she will complete blood count and kidney function. Sometimes there may be involvement of kidneys in the CA cervix, and liver function test, any metastasis, and urine routine and midstream urine culture sensitivity to look for infections. And here, so examination under anesthesia has to be done for we need to take a cervical biopsy, and also we need to stage the disease. And apart from this, we need to stage the investigation to look for the extent of involvement. We'll also take chest x-ray and ultrasound abdomen with the bladder, kidney ureter bladder. And also if needed, we'll also check intravenous pyelogram to check for any kidney involvement, and MRI or a CT abdomen to check the extent of the lesion, soft tissue involvement and nodes.
Okay. Now, your suspect, it has come out to be a cancer, early stage cancer. You are waiting for biopsy report. How you are going to manage her further? We'll discuss the biopsy report, discuss the investigation once available.
Sorry, ma'am.
The biopsy report has come positive for malignancy.
Okay, ma'am.
Okay.
So, stage something you said.
Yeah. It is a 4 centimeter mass involving the lower cervical region, not extending into the vagina or uterine cavity, parametrium free.
Okay. So here the patient will be explain about the diagnosis by breaking badness in a sensitive and empathetic manner, and she'll also be connected to the counselors and support groups going through such a difficult situation. And so here the further referral will has to take place in a rapid pathway, in a 2 weeks pathway to MDT. The MDT team consists of my consultant and radiologist, radiotherapist, oncosurgeon, and medical oncologist, special nurse, the Macmillan nurse, and palliative care physician. So coming to the stage, so this 4 centimeter growth without any involvement of parametrium and not involving the lower third of vagina comes as a stage 2A2. So here she will be offered further treatment after discussion in with the MDT team. So 2A2. So here the pros and cons of surgery versus radiotherapy will be discussed. So there are two options available for her with the treatment options, and her wishes will be respected.
Okay. Now, how you are going to manage her? How you are going to treat her?
Okay. So
Depending upon the stages, depending upon the several stages, how your cervical cancer will be treated.
okay. So in actually the advantage of cervical cancer is both radiotherapy and the surgery gives equal cure rates. So in stages up to 2A, up to 2A, we can offer both surgery and also as radiotherapy. But in early stages with lesions 4 centimeter or more, like 1B3 and 2A2, according to the recent recommendation, uh, radiotherapy is preferred because by doing positive margins, positive lymph nodes, and parametrial invasion. So after surgery comes as again the candidate for chemoradiotherapy. So patient is experiencing double morbidity because of both surgery and the chemotherapy. So with respect to surgery, so it will be done by an expert oncologist after a proper counseling. So surgery, the advantages of surgery is it removes the all the tumor cells, but in lesions 4 centimeter and above, again the clearance margin is difficult, And also surgery in terms short-term complications like infection, injury to the nearby structures like ureter, bowel, bladder, and blood vessels will be more, but if identified, which will be corrected earlier. And long-term morbidities like problem with the sexual dysfunction and bowel bladder disturbances, again which can be corrected by doing a nerve sparing radical hysterectomy with pelvic lymphadenectomy. So in early up to 1A1 we can offer an extrafacial hysterectomy. From 1A2 we'll offer a modified radical hysterectomy with pelvic lymphadenectomy.
Okay.
And from the 2B we'll offer an chemoradiation. And now
Okay.
1A3 and 1B3 and 2A2, again recent recommendation, chemotherapy is preferred. Surgery is preferred only in a young women in a selected patients after discussing in MDT.
Okay. So if we decided to go for surgical management, completed your time, but I do have some questions, so I will take extra time.
Okay.
Okay. Uh, Now, if you we since it is 1B3, 1B2 actually, according to
Okay.
the according to the size of the tumor, it is 1B2. What surgical approach you will decide for this patient?
So 1B2 this
What surgical? How you will be treating her surgically? What will be the procedure?
so 1B2, so we can go for a radical hysterectomy with pelvic lymphadenectomy. So again it will be by
What it
following.
involves? What is involved in radical hysterectomy?
Yes, ma'am. So by following a WHO safety checklist, so here, so with the along with the uterus, we need to take out the supports till its attachment, uterosacral till its attachment, uterine artery at its origin, and upper half of the vagina, cervix, uterus, along with uterosacral attachments and uterine artery its origin, and round ligament till its lateral attachment will be removed. And apart from this, pelvic lymph nodes on both sides, both external iliac, internal iliac, obturator nodes will be removed. So, and it will be sent for histopathology to check for positive lymph nodes, parametrial invasion, and positive margins, and any lymphovascular invasion, tumor size. So, will be checked, and apart from this, along with grade and the type of the cancer.
Okay, now the surgical specimen has shown that there isn't any lymph nodes or any lymphovascular invasion.
No lymph nodes, ma'am.
No lymph nodes. So how you are going to treat?
No lymph nodes and no lymphovascular invasion. And if there is no positive margin and there is no parametrial invasion, we can follow up her without any additional radiotherapy or a chemotherapy. So follow up will be initial 2 years every 3 months and next 2 years every 6 months, then yearly follow up till lifelong.
Okay. And what test you will be suggesting during follow?
So follow-up symptoms first, patient will be asked about the symptoms. According to the symptoms, we'll prescribe this thing. Then follow-up thing, we can take a we can take walt smear. And if the patient complains of any symptoms, then we can go for a CT abdomen and pelvis or PET scan depending on the symptoms and MDT decision.
Okay. I do have one more question which is not included, but I think in view of recent talk articles the RCOG is giving, I would like to ask this. So what is extentration surgeries? Extentration surgeries.
So extentration surgeries means so it is it is consist of two anterior extentration, posterior extentration. So it is generally preferred in the patients who has recurrences or in advanced stage after radiotherapy with bowel and bladder involvement. So anterior extentration is so removing the bladder and posterior extentration is removing the rectum and posteriorly. So after removing the bowel and bladder, so ureter will be either anastomosed to ileal conduit or it will be connected to the skin, and the same way rectum will be removed and colostomy will be offered. Usually preferred in a central recurrences.
Okay. Okay, that's it. Now coming to feedback. What do you think?
Hmm.
Anybody would like to give her feedback? Audience, welcome. Come up fast. Manikam ma'am? No? Anybody? Okay. Madhulakshmi, you only tell your own feedback, then we will go.
This radical hysterectomy extent part, something I told correctly, completely I didn't tell.
Okay. Okay. It is time management.
Yes.
Okay. Because there were 4 or 5 questions and you need to manage it very effectively. So I will suggest you to do not go blindly when it is a task of structure discussion. In the question one, you took almost 3 to 4 minutes.
Clinical examination means we need not go to history, ma'am. That doubt I had.
Yeah, so if it is a straight question, answer
Um,
is should be
okay,
straight.
okay,
If
ma'am.
I would have asked you management, yes,
Okay,
at that time you have to take a detailed history.
okay, ma'am. There
Okay.
I cut short.
Yeah, that is one is mistake. And even if it is you are taking a history, too
Mm,
much of irrelevant history without justifying why you are asking those questions will not give you any mark. On the top of it, it will downgrade your information gathering scoring.
okay, ma'am.
You will fail in that domain if you will ask unnecessarily questions just to gather the information. You will be downgraded. Okay. So remember, if you want to ask, you need to justify why you are asking that history. That is what they want you to do. Okay. So
Okay,
that
ma'am.
is my, yeah, that is my feedback. Apart from that, knowledge part is good. Only thing is, mm, why he's not able to join? Dr. Ong is typing. Okay, so knowledge part is good, but we need to know the staging thoroughly, all type of staging thoroughly for the RCOG exam, MRCG, because there they are not going to give you stage one, stage two, stage three. They're just going to give you the broader aspect of the uh, involvement. With that only within that 2 minutes time under stress, you must now you are out almost stress free. We are just having one-to-one discussion. At that time in the real exam you will be always stressed out. If some situation or some information they had given, you will take so much of time to grasp it and then stage it. Hmm? So your in oncology module, all the staging and management needs to be very thorough because identify you need to identify what is the stage of the disease so that your management will be according to that, and if that you were able to identify, you will be a clear it will be a clear pass for you. Okay, yes or no? Hmm?
Yes, ma'am.
Sorry, ma'am,
So
I disturbed the question.
Yes, madam.
okay,
Ma'am,
somebody wants to
quickly,
say somebody.
yes, ma'am, I want to tell you one thing, ma'am. Ma'am,
Hmm?
instead of all this investigation, I mean, this examination under anesthesia, it is now replaced by MRI, no ma'am?
Yeah, it has been actually, but even in clinical scenarios, still they are going for examination under anesthesia simultaneously with the help of biopsy. They can pose this patient for biopsy with examination under anesthesia. So, although it has been not replaced, but the MRI has taken over the clinical examination part.
Mm.
But
Yes,
still,
okay.
you
Thank you,
mention it, okay? Still, you mention it.
Actually, previously it was a clinical staging for a CA cervix, so now they changed to considering all the imaging before.
Yes, so it is image based, but examination under anesthesia up till now we do not know, means up till now whether it will be included in their answer sheet or not. So to be on a safer side, 1 point will not at least downgrade your mark. Yes, we are taking help of investigations like MRI, even PET scan. Means they are doing PET scan also to now also MRCOG is saying X-ray chest for ruling out chest secondaries. Okay, but in our clinical scenario, we are using advanced imaging like CT, PET scan. So at least say we would like to rule out secondaries with the help of imaging like CT abdominal, chest, X-ray or CT chest. So you are just, you know that you are very much aware that you wanted to rule out secondaries also. So investigation wise, she was okay. That question she has answered very well. My concern is regarding her first question and not asking a relevant history.
Yes,
The
ma'am.
way she started, she didn't end it unless and until she was not completing her thorough format for the history. So that will not go very well. Then the second question was very well answered by you. Since there was a confusion for this staging, okay, so you got confused at that time, and at the time of management you can say that here you would like to take a brief history from this patient, then examination, confirmation, and the management. So management, yes, 2 week pathway, that is rapid pathway MDT approach, where since it is 1B2 where the surgery will be done, you have to mention that also. It will be radical hysterectomy where it will be done, you have to mention that also. In
Four
radical hysterectomy,
centimeter, 4 centimeter means that comes as advanced stage, ma'am. Only less than 4 only B2.
B2. Less
Yeah.
than 4,
Less than 2, 2 to less than 4,
2 to
4.
4. 2 to
Yeah.
4, this is what I have just. 2 to 4 is okay, na? 2 to 4 centimeter. If it is more than 4 centimeter, it is 1B3.
Actually, more than or equal to 4. Like,
Okay.
in that FIGO article, I'll once again check, ma'am. It is given us like more than or equal to 4. They are not preferring surgery as a first option now.
First line.
Yeah,
Okay.
according to recent FIGO.
Yeah.
More than or equal to 4 comes higher staging.
Okay. Because I had tried to search it out. The Konje is actually a old book. Okay. So they had this book is previous to the previous to this Figo stage. I think so. They must have started writing it. So they had mentioned somewhere it is 5 centimeter, but then I thought of keeping it 4 centimeter for a better knowledge purpose. If you are having a reference for that, you can
Yes,
just share
I'll
it into
send
the
it to
group.
the group. Yes,
Yeah.
ma'am.
But so that idea should be very clear. Even if it is 4, it will be 1B3. Hmm? No
Yes, ma'am.
lymph node, no lymph node, young patient, then yes, surgery will automatically will be the first line of choice. You think that way also, no comorbidities. So surgery, yes, because 1B3, it is not adamant, they're not very adamant that no radiotherapy should be done. It is like surgery, radiotherapy equal to they will be having equal equally can be decided, means which should be gone for this. Survival rate and relapse rate will be discussed at that time. So both the options can be given to the patient. Uh, 1B3 and 2A. 2B onward, we are knowing that it is only radiotherapy or chemotherapy. Advanced stage, it is palliative therapy. Yes?
Yes, ma'am.
Okay. So that is what my concern was. I wanted to ask you stage-wise treatment of CS cervix, which one needs to know. Most of the points you had asked very correctly. 1A1, 1A1. Here, a simple conization, simple leads where the clear margins are available with simple hysterectomy. This can be offered at 1A1 stage. What is the role of radical trachelectomy when you can offer this radical trachelectomy? Can you just put some insight on that?
So radical trachelectomy, it is offered for as a fertility sparing surgery. Again, it can be offered in stages like 1A2, 1B1, only in two stages. Up to 1B1 only we can do fertility sparing surgery.
It is only up to 1A2, not beyond that.
B1,
1A2, I think, and less than 2 centimeter.
yes, ma'am. That's a
Lesions.
1B1 it comes. B1 has B1, B2, B3. No, in B1 less than 2, we can do a fertility.
Yeah, less than 2, 1B1 and 1A2, where the lesion will be less than 2 centimeter, and it should be fertility sparing.
Sparing
If the
surgery.
patient is keen on getting pregnant in near future, so fertility sparing surgery, so that there comes that one is okay. So that there comes this fertility preserving option. Otherwise, if no fertility preservation, then radical hysterectomy. Hmm? And 1B3 to 2A2, where initially they used to say surgery, now they had given surgery or radiotherapy, but avoid combination of both. It should be either surgery or it should be either radiotherapy. The combination of both should be avoided to minimizes the morbidity associated with both the therapy. If we are going for surgery, then it should be a complete surgery, no radio chemo. If it is a radio chemotherapy, then the surgery should be avoided to minimizes the morbidity associated with both the modalities. That is what the newer guideline recommends. And the advanced stage, we all know that to be onward, it will be radiotherapy, chemoradiotherapy, which will include, which will be the chemotherapy? Platinum based, cisplatin.
Yes,
Yeah. Chemotherapy, radiotherapy. Radiotherapy will be external beam or brachytherapy. It depends upon the expertise what they will be offering. And the last advanced stage, it will be palliation. So that is okay. Then the surgical treatment, yes, I wanted to just, miss, they will not go in detail. They will just ask you what will be the next question was appropriately answered by you, means the treatment, what treatment you will recommend, that is radical hysterectomy, and what are the means components of radical hysterectomy. So that was answered by you very nicely, not to worry about that. Pros and cons also you had mentioned very nicely. uh, Counseling, Macmillan Cancer Support Network, you mentioned everything. And the last question was, if surgical specimen show no involvement, yes, the follow-up. Okay, follow-up, you missed out on clinical follow-up. Patient will be offered means it will be symptom based followed by investigation based. So always say all those follow-ups thoroughly. And this is accentration. So just go through quickly through my answer key, what I had mentioned here. Very nicely you started with the S bar. When I asked you first question, I had made it very simple because I had asked only examining the patient what will make you suspect cervical cancer. So S-bar tool, suspected case of CS cervix, referred from GP surgery in view of postcoital bleeding with foul-smelling vaginal discharge. So on inspection, a generalized examination here, depending upon the staging. If it is advanced stage, patient might be cachexic, anemic. Even the patient might be foul-smelling or smelling of a urine. Means I don't know whether you have come across a advanced stage CS cervix patient, but you can make it out very distant means distance. You can very easily make it out that the patient must be having CS cervix because they smell typical of urine many a times because of that involvement of kidneys and bladder, foul smelling. So that is one point. It is general examination. On per speculum, per vaginal, per abdominal examination. Yes, any mass which is means per abdominally, less likely there will be any mass. But on per speculum, per vaginal examination, if it is per abdominal mass, then most of the time it will be either a endometrial CA or ovarian CA. Per speculum, per vaginal examination, here you will be seeing a friable, fragile, fixed, exophytic, endophytic, a different kind of mass which will be bleeds on touch. Okay, the mass, the peculiar lesion will bleeds on touch, and there will be foul smelling vaginal discharge. On per vaginal examination, the growth will be fixed, friable, irregular, and mostly it might be involve the lower vagina, uterus, or a parametrium. So lateral spread. So these are the findings which you will be seeing it on the clinical examination. My second question: what investigation you will undertake? Biopsy, but colposcopy guided biopsy still a confirmatory, so you will be going for that. That will be first step. You started with the reverse order. I started with the first confirmation. If confirmed on biopsy, then staging, and then the surgical fitness. It goes more logical. Okay, staging of disease needs examination under anesthesia, ultrasonography, or MRI abdopelvis, because MRI abdopelvis will gives you a clear idea about the tissue extent, and you can stage the disease with the help of MRI abdopelvis and X-ray chest to see the distant metastasis. And now for the further fitness, whether it is surgical fitness, whether it is radiotherapy fitness, but we need to know means what are her baseline blood investigations, which includes full blood count, liver function test, kidney function test, electrolytes. Okay, so all these investigations one would like to undertake while managing this patient. So steps in her management. Now I would like to take a detailed or brief history here. My brief history is her smear was 5 years back. So why she missed her smear? It's an important question I would like to ask. Meanwhile, I will emphasize, yes, very nicely you have mentioned here that you would like to introduce yourself and take a detailed history or brief history, whatever history. Onset, duration, progression of symptoms, smear history, which is very important, then risk behavior. Here, I would like to take a history of her risk behavior, means uh, whether she is having any previous history of multiple sexual partners, immunocompromised conditions like HIV, then smoking, oral pills, and her future fertility desire less likely because she's already, the age is, what is the age of the patient?
43.
40? Yeah, so 43, so less likely here the fertility desire will come up, but the risk behavior I would like to take. Uh, examination, after that would like to offer her examination which we had confirmed in the beginning. Once we had suspecting a CS cervix, it will be a partial BBN or a complete BBN, and we need to tell here patient that the confirmation will be after getting a biopsy report. So it will be by partial BBN, explaining her the probability of having cancer cervix, but needs to be confirmed after biopsy report, and which will be done under colposcopy guided, followed by staging with investigations. And once all these investigation reports are available, the 2 week, this will be followed up in 2 week pathway. MDT will be formulated for further management, and depending upon the stage of the disease, on the basis of investigation, the further management will be there. So now depending a broader staging here I had just mentioned. So stage 1A1, conization or leads or simple hysterectomy. If not if completion of family is there, then simple hysterectomy will also be there, will also work. Stage 1A2 or 1B2, and less, if stage 1A2 or 1B1 we had discussed less than 2 centimeter, then radical trachelectomy can be offered for fertility preservation. Otherwise, up to 1B2 we can offer them radical hysterectomy with pelvic node dissection. Stage 1B3 and 2A2 is now the newer things comes up. They just want to avoid combination treatment of radical surgery and post-operative radiotherapy. So the patient which suits better, the patient who will be getting benefited by surgery, in those cases only surgery will be offered, provided the lymph node should be negative, so that the patient will not require further treatment. Otherwise, if you are thinking that there is a high possibility of lymph node positivity, then it will be a combination of chemoradiotherapy, no surgery. Okay, so combination needs to be avoided here. That is the newer guideline or newer thing which is coming up. And then apart from stage 2B onwards, it is always chemoradiotherapy, either in the form of brachytherapy or external beam radiotherapy. And advanced stage, it is palliative care or pelvic extension in suitable cases. So I thought of adding that question also. What surgical treatment will you recommend in her, depending upon, okay, we will just see here that the patient has been diagnosed as 1B2. So it will be radical surgery. So radical surgery involves very nicely, Dr. Muthulakshmi, you have explained, it's removal of uterus, bilateral fallopian tubes, ovaries, cervix, vaginal cuff. It is not 1/5, it is half, not the 50%, it will be upper 1/3 of the vaginal cuff, ligation of uterine vessels at origins, and the ligation of uterosacral support or any other supports from its origin. Okay, so those so that we will get a adequate tissue which will be free of cancer. For that, the surgery is the option which will be done at a cancer center by oncology team. The approach either can be open or lap. Yes or no? We can offer here open or lap. Both options we can offer. Yes or no?
Yes, ma'am. Yes.
Yeah. In ovarian, it will be always staging laparotomy. It will not be keyhole surgery. Always remember this. Pros and cons very nicely, means very elaborately you had explained. So I just kept it very short. Infection, injury, because it's an extensive surgery. So injury, lymphedema, bleeding, anesthesia risk, VT, and long run sometimes we may encounter the fistulas. Post surgery HPR, need for further chemotherapy or chemoradiotherapy. Once the procedure has been completed, patient will be offered counselor, Macmillan Cancer Support Network, and patient information leaflet also. Surgical specimen shows no involvement of lymph node, what will determine whether she will have further treatment. So here we would not like to have further treatment in the form of radio or chemotherapy. We just need to follow her up at a frequent interval GP surgery, including a gynae clinic also. So initially 3 monthly for first year, then it will be 6 monthly, and then it will be, I think, annually till she is alive. The symptomatic follow-up, whenever she will be having any spotting, bleeding, she needs to follow up. During the follow-up, she will be offered vaginal wall cytology, plus minus colposcopy depending upon the lesion, baseline blood investigations, and she also will offer a PET scan or MRI scan depending upon the lesion, if there will be any visible lesion, and X-rays. So depending upon her further response to the primary surgery, she will be followed up in the GP surgery or gynae clinic. Now, what is extension surgeries? Yeah. So this is basically en bloc removal of uterus, fallopian tube, ovaries, vagina, urethra, bladder, rectum, occasionally anal canal, vulva, and perineum, with diversion of urinary and fecal. Okay, so stoma will be always there, either single stoma or both two stoma. That is, one is ureteric stoma and the second one will be fecal stoma. Most indication for gynecology, indication for pelvic extension surgeries in gynae are, most of the time it will be recurrent cervical cancer following radiotherapy. Other cases where it will be offered will be locally advanced gynecological cancer, in particularly primary. These are other indications. Less radical surgery or radiation therapy had failed. Recurrent gynecological cancers that have previously been eradicated, less often for locally advanced or persistent disease following primary treatment. So it is actually a very extensive surgery. So the morbidity associated with the surgery is pretty high. So there are certain indications and prerequisites whenever one will be planning this surgery. So yes, rightly mentioned by Dr. Muthulakshmi, there will be anterior extension and there will be posterior extension. So the prerequisite, ideal case selection. The case selection should be very appropriate. It should be always a central disease and no lateral wall involvement needs to be there. Size of the recurrent mass should be as less as possible. Distant metastasis is an contraindication for this procedure. duration from primary treatment. If earlier the primaries appear, then it will not be a success, it will not give us a successful outcome or very high means after having such a morbid surgery, the patient prognosis or patient's life expectancy will be less if the duration from primary treatment will be minimum. PS, that is performance status of the patient. The patient needs to be physically, mentally fit to undergo this surgery, because it is a physically, this surgery will be take a two-step surgery. These are, first will be removal of the cancer, and the second will be reconstructive surgery. So the surgery is very extensive. So first is physical fitness we need to know, and the emotional, because it's going to be having a very much emotional trauma on the patients along with the stoma. Counseling is very important. So these are the in general prerequisites associated with this surgery. Now coming to the domain wise scoring, very well done, but you need to remember what has been asked to you, Muthulakshmi. Answer those only, no generalized template uses here. Obtain good history, smear, risk factor for CS cervix, initiates appropriate investigations to help make a diagnosis examination findings, investigations which we had discussed, checking her ultrasonography, biopsy, examination under anesthesia, check kidney, liver function test, full blood test, chest x-ray, and interpretation of GP letter. That is information gathering here. Communication with patient and families, in this format, introducing yourself to the role player, offering a counseling, offering a support. This is what will be involved in the communication with patient and families in structured discussion. Communication with colleague, MDT, support team, and counselor. Okay, MDT involves oncologist, gynec-oncologist, radiologist, cancer nurse or Macmillan nurse, colposcopist, and histopathologist. Patient safety, MDT within 2 weeks, cancer pathway, coping strategy or counselor, cancer nurse specialist, a certain drug allergy, investigation, appropriate treatment, especially radical hysterectomy, awareness of cancer pathway, follow-up post-surgery, follow-up after surgery, discuss pros and cons of the surgery, which we had discussed very nicely, and emphasize on cervical screening, which is important here. Applied clinical knowledge, staging of cervical cancer, justify the investigation, discuss the treatment options according to the staging, radiotherapy versus surgery, complications, immediate and long-term prognostic factor, demonstrate knowledge of current literature on management of cervical cancer. Very nicely done. You have shared, I have just seen, so I will go through it. Okay,
Yes.
so very nice attempt, good task so far as. Anybody is having any question?
Fertility sparing mean trachelectomy only up to 1B1, ma'am. That they have given only 1B1.
Less than 2 centimeter.
Less than or equal to 2 centimeter.
Okay, okay, okay.
And
So
4
because I know,
centimeter. Yeah, yes, ma'am. 4 centimeters B2, more than 4 only, like it comes, the radiotherapy has also option 1B3 and 2A2. More than
so
4.
4 centimeter is up to B2, na? What
Yes,
I
ma'am,
have.
B2. Yeah, B2.